I'm very pleased to see this. And I'd actually like to ask Adrian to take over here and to talk about how this sort of mini fellowship training opportunity concept relates to pediatrics and how pediatrics evolved from, I think, in the early part of the 20th century with services to children with cerebral palsy or polio, their disabilities, and later on to the kinds of developmental disabilities that were genetic kind of developmental disabilities that resulted from taking care of high-risk premature infants, which led to developmental monitoring of these high-risk premature infants, and to the pediatric the world of pediatrics beginning to embrace the services to children with all manner of developmental disabilities.
Thank you, Les. I think that developmental disabilities, the care of children with developmental disabilities was always very much at the core of pediatrics. I mean, some of the early prominent pediatricians in my training, people who we read about like Illingworth, who studied children with cerebral palsy, that was always, I think, felt to be very much at the core of pediatric care, the care of children with chronic conditions and with developmental disabilities. And so it was clear, for example, when I did my pediatrics residency in the mid-'80s, that many of the children whom we were taking care of from the intensive care nursery and on through all of the other subspecialty clinics that we were involved in, many of those children had developmental disabilities, yet it was not really kind of explicitly recognized as a subspecialty at that time. It didn't exist as a subspecialty, and it probably got short shrift in terms of training. But still, it was very much part of our bread and butter in pediatrics training. And so I think as the move towards a clearer identity of the subspecialty of developmental pediatrics, or the two boards that developed in neurodevelopmental disabilities and in developmental behavioral pediatrics, as those two subspecialties develop a clearer identity as discrete subspecialties within pediatrics, there was a kind of a backlash or a tension, perhaps, because many felt that they didn't really belong as separate subspecialties, but they really were part of the core of pediatrics. And I think that tension continues to play out in our field. Although I am a subspecialist in pediatrics, there are many in my subspecialty, many leaders in my subspecialty who continue to practice primary care general pediatrics. And they continue to see the field of developmental pediatrics as being very much at the core of the general field of pediatrics.
Very good point. Very good point. In fact, if we sort of express what the diagnostic spectrum is within developmental pediatrics, ADHD, autism, many of the genetic conditions, and follow-up of the high-risk infants, just for a starter. And if we sort of look, many general pediatricians are taking care of kids with ADHD. I don't hardly see them anymore. Yes. I don't know if you do see many of them.
Yes, certainly there's been a change. I think as the years go by and as there's more opportunity for primary care pediatricians to really be trained in these areas of need, I think that increasingly the world of the primary care pediatrician is encompassing care of a broader and broader spectrum of children with developmental and behavioral challenges. We see that particularly now with some of the difficulties in provision of mental health services and the organization and reorganization of mental health services, there are many, many more children with mental health care needs who are who comprise a very large part of the effort of primary care pediatrics. And similarly, there are, as you said, a lot of primary care pediatricians who have realized just how prevalent in their patient populations are conditions like ADHD and learning disabilities and autism, and they have really been looking for opportunities to learn more about these conditions so that they can incorporate them into their primary care practices.
And one of the other things that we frequently hear, and because you do it, is that many, not just general pediatricians, but behavioral developmental pediatricians and neurodevelopmental pediatricians find themselves taking care of young adults in their 20s, 30s, sometimes even in their 40s, because they don't have adult providers to refer them to who are familiar with the conditions, so that pediatricians find themselves, becoming family physicians or, general internists, and the kind of medical problems that they begin to have to deal with in these children and youth who have grown up and, now reached adulthood. And again, one of the reasons that, we've developed the mini fellowship and want to try to develop a consensus sort of collaborative approach to training adult physicians so that we can model what you all have done in pediatrics and really provide excellence in care, not just for their general medical problems, but for their developmental disabilities and related conditions. So that's part of why we're here. Could you speak a little bit about how you developed the two subspecialties, the behavioral developmental and the
Yes.
neurodevelopmental? How did there seem to become a need for two different approaches?
Really, there wasn't. I don't think that there was really ever a need for it. I think it involved clashes between personalities and programs, and I'm not an expert on the history of all of this, but in a nutshell, there was increasing interest in the field of developmental pediatrics, and there were centers of excellence that were developing training programs and that were producing cadres of pediatricians with particular interest and experience in
This is in
these
the
fields.
mid-1980s or so?
This would have been earlier. This would have even been in the 70s and perhaps early 80s. And I would say that the two centers that were perhaps most influential were Boston and Hopkins. Right? I think that the Hopkins group seemed to be more closely aligned with neurology and with disabilities. The Boston group seemed to have perhaps more of a broader concept of this evolving subspecialty within pediatrics that certainly included developmental disabilities, but also included behavioral aspects of pediatric conditions. So, for example, at the professional at the Society for Developmental and Behavioral Pediatrics that was established, I think, in about 1982, and that I began to attend as a fellow in 1987. There were presentations, academic presentations, papers delivered on things like colic and developmental aspects of child abuse. And a number of other behavioral concerns in pediatrics. I mean, there was an interest in encopresis and enuresis and a sort of a broader set of concerns than might have perhaps been embraced by those who were interested in more neurologically based developmental disabilities. And so I think that these two groups, instead of coming together and embracing one another as a single movement within pediatrics were drawn apart, I think, by some personal animosities between some of the leaders in these programs, and then independently moved towards establishing their own separate societies and establishing their own separate subboards in pediatrics. The one group allied closely with neurology and developed a subboard in neurodevelopmental disabilities. The other maintained a broader focus, continued to struggle with its relationship with general pediatrics. That is, continued to think of itself in some way as belonging in general pediatrics rather than as a distinct subspecialty. And that group developed a subboard in developmental behavioral pediatrics. I know, I have my feet in both camps, as it were. I know that there are many who are Hopkins trained and who have their subboards in neurodevelopmental disabilities who do the same work that I do, and there really isn't a significant distinction, I think, in our approaches. But at this point, it is rather an accident of history that there are these two separate boards that essentially have much the same scope and much the same purpose.
Have individuals in those two subspecialties, do you think, still maintained a general relationship with the field of pediatrics as a whole? Have you been able to continue to sort of be one sort of big family in a sense in terms of your vision and collaboration and sort of ultimate goals that you have in terms of providing care, or have the worlds really sort of become their own?
To some extent there has been some rapprochement. I think, for example, in the American Academy of Pediatrics, there is an entity there called the Council on Children with Disabilities. And the council that I was actually co-chair of that council several years ago, and that council, or its predecessor, the committee, organized that meeting at Wingspread that produced the consensus paper on transitions in healthcare. But that council comprises neurodevelopmental pediatrics folk and developmental behavioral pediatrics folk together, and I think that's been one example of efforts to bridge that gap. But I think that the two subspecialties are likely to continue, and they each are represented by their own professional societies, and although there are many people, as I say, who have memberships in both,